DBS has undergone quite a transformation over the past 10 years. We've gone from a procedure, a technique which was initially licensed and utilised to treat movement disorders such as Parkinson's disease, and we went from the point where it was considered relatively experimental in the treatment of Parkinson's disease to the point now where we have very good level 1 evidence supporting its efficacy, and it's a very well established strategy for those patients. But there are a number of other conditions that we're now looking at using deep brain stimulation to treat, and I was going to talk about a few of these conditions and about our experience with these. The first field is that of psychosurgery, and depression is really a major problem for the community and for those individuals affected. And according to the World Health Organization, by 2020, this will be the second leading cause of disability worldwide. And this is a big problem. The other problem is that around a third of patients with depression fail to respond to the usual pharmacological and ECT therapies which may be offered. And those patients are at risk, including at risk of committing suicide. So deep brain stimulation was really a follow-on to some of the earlier surgical strategies of prefrontal leucotomies and other types of destructive procedures which were employed in the mid-1900s and which fell to the wayside as psychosurgery experienced a period of disrepute. Now it's coming back in the form of deep brain stimulation. There are a number of structures in the brain that are being looked at to stimulate in depression, and this is based significantly on functional neuroimaging studies which demonstrate metabolic changes in particular areas of the limbic circuitry. Probably the biggest group is that in Toronto, and they're really championing the subgenual cingulate gyrus, or Brodmann's area 25, and they have a wealth of experience in deep brain stimulation for depression in those patients, and I'll talk a little bit about their results. The other areas are the anterior limb of the internal capsule and the nucleus accumbens, and the lower three structures listed are much less commonly utilised. So it's really those top three structures that are utilised. So I mentioned Lozano's group in Toronto. They've published extensively on subgenual cingulate gyrus deep brain stimulation for depression, and their response rate is between 50 and 60% in most of their publications. And that's pretty good when you consider that these patients are patients who aren't responding to any other measures. Then if you look at the groups, a lot of European groups are using the anterior limb of the internal capsule, going down into the area of the nucleus accumbens, and they're experiencing significant benefits in around 50% as well. So we seem to have at least 50% of patients on the data available so far that respond well to deep brain stimulation, and doesn't seem to matter at the moment which of those three structures you select. So we looked at the literature about 5 years ago and decided that for us probably the nucleus accumbens was the best target, and so we started participating in a multi-centre Medtronic-sponsored worldwide trial and recruiting patients slowly. These patients had to have major depressive disorder, so we excluded patients with bipolar disorder. We were worried about pushing them over the top when they became manic. These patients all had to have a number of years of consistent depression, and they had to have tried all of the pharmacological therapies. They had to have tried electroconvulsive therapy, and more recently they must have tried transcranial magnetic stimulation. These patients are all submitted to the Psychosurgery Review Board, which is another flow-on from the days of the dark days of psychosurgery, where it was used in many places indiscriminately and with poor effects and disastrous consequences. So we have to submit these patients in Victoria to the Psychosurgery Review Board. There's a panel, there's a psychiatrist, there's a lawyer, there's a layperson, there's a neurosurgeon on that panel, and they consider the details of every case, and they then give us the final go-ahead, or they refuse to give us the go-ahead if they don't believe that the patient is suitable. So there are a few boxes to tick with these patients. Initially, as I mentioned, we started off with nucleus accumbens, and in the first patient we didn't really see any on-table stimulation effects, and we thought, well, this isn't very exciting. We'd been doing a lot of Parkinson's disease surgery where they have the tremor and you can shut down the tremor straight away, and it's quite satisfying for everyone. But in that first patient we didn't really see any benefit on the operating table. We'd had a chat to some of our European colleagues after that and looked at the literature, and talking to people like Bart Nutten from Belgium, they'd moved a bit more posteriorly, and so we started to explore that posterior area, and as we did that we found that you could more easily induce mood changes on the operating table, and I guess that gave us a greater degree of comfort. So for the subsequent patients we ended up moving back to a related target called the bed nucleus of the stria terminalis, which sits just behind the anterior commissure. When we stimulated intraoperatively, what we found was that patients would often go from being very low mood, not very interested, not looking around much, not wanting to converse or interact with the other people in the operating theatre, to having an improvement in their mood. They'd start to look around, they'd start to ask questions, they'd become more talkative. And we would see that quite often as we stimulated, and as we stimulated more proximally, getting down to the target, we'd see positive benefits. And then if we kept going, we'd often see that they became dysphoric. Their mood deteriorated fairly dramatically, and you'd only have to move your stimulation about 1 millimetre or so, and you could see a fairly dramatic shift in their on-table response. So we also noted that the pattern did vary markedly between patients, and we don't really have enough intraoperative data at this stage to make to draw any solid conclusions. But they're things that we look for intraoperatively. When we looked at our results, and we're now out to a mean of nearly 21 months follow-up on these 5 patients, 2 of the patients are in remission. 2 of the patients have had a greater than 50% benefit in terms of their depression rating scales, and 1 of the patients only improved about 10% when you look at those 2 scales. So if you look at the scales on the right-hand side of the screen, what we're looking at is a mean reduction in their depression rating scores of around about 60%, which is fairly good for patients in their situation. The 1 patient that didn't really have a response, and I've called it a partial response, but it's a pretty minimal response, that patient we think had borderline personality disorder that was masked by their depression at the start, and they were seen by psychologists, psychiatrists, neuropsychiatrists, and in retrospect it's now clear that there are, as her mood has lifted a little bit, a lot of the borderline personality traits are starting to come out, and they're confounding our interpretation of her response, and they're probably affecting her response as well. So we're looking at ways that we can avoid that situation in the future. The second big psychiatric condition that's being treated with deep brain stimulation now is obsessive compulsive disorder. This isn't as common as depression, but can be equally as devastating for the person affected and their family. These patients have recurrent obsessions and compulsions. This condition often manifests during adolescence or even childhood, and it can often get worse with time. Fortunately, 90% of these patients can be treated with psychological strategies and pharmacological therapies, and so most of them don't actually need to be considered for surgery. OCD does have a fairly good base of literature when it comes to surgical treatment, and most of those studies have been done with lesioning, either open lesioning surgically or with stereotactic radiosurgery such as the gamma knife. And if you look at the results there, I've just summarised really the response rate. The thing to note on that slide is that the response rate does vary quite a lot. And it's not particularly great, but it's not too bad. But when deep brain stimulation became accepted for other conditions, it was logical to look at applying it to the treatment of OCD. Again, like depression, you're looking at multiple targets that can be selected on the basis of our knowledge of the pathophysiology of OCD on the basis of functional neuroimaging studies and on the basis of response of obsessive compulsive disorder traits and signs to stimulation for other conditions, such as patients with Parkinson's disease might have had STN stimulation and their OCD features got better, so people started looking at the subthalamic nucleus. So again, the response rate there, when you look at the literature, does vary, but you're probably looking at around about 50 to 60% of patients responding. We've done 3 OCD patients. We've done a lot of patients with Tourette syndrome that have also had some OCD features, but we've done 3 patients primarily for the treatment of OCD. One of them was done last week, so we don't have much follow-up on that yet. But the 2 patients that we do have follow-up on, one patient had significant Tourette syndrome and OCD, and we decided to put electrodes in the bed nucleus of stria terminalis as well as the globus pallidus internus, with the rationale being the GPI was the target for the Tourette syndrome and the BNST was the target for the OCD. She has obtained a significant benefit, particularly when at home, but unfortunately when she goes out in public, her tics come back. So she's got a partial benefit. Her OCD symptoms are not as pervasive or as repetitive as they were before, but the great thing for her is that she's been able to substantially reduce her medication intake. The second patient also had an improvement in her level of functioning and a reduction in the number and frequency of distressing thoughts. So we're still going through those, trying to quantify things for those.